Welcome to Credentialing Chronicles, where we spill the doctor's tea, honey, hotter than your morning coffee.
And we're spilling it across America, state by state and license by license.
Ooh, I'm Shannen, and honey, she is Nyleen, and we are just a couple of sassy credentialing pros with front row seats to all this crazy chaos.
Yes, from coast to coast, fraud scandals to hospital drama they hoped you'd never find.
Yeah, but we find it, girl. So grab your coffee, your compliance checklist, and what, Nyleen?
And let's get into it.
Hell yeah. Well, Nyleen and Shannen sitting there talking about you while you pull up a chair. They holding everything.
Honey, Delaware is small, but don't let the size fool you, Nyleen.
Oh, no.
Right? Because, when I think of Delaware, I think corporations, because, you could go there, have a corporation.
Everybody, seems to have a corporation or a business in Delaware. I got to check that out.
Well, you could be anonymous, I believe, don't quote me. And you don't need to live there, so, I think there's like a lot of benefits to be in Delaware. But what about credentialing? Really, that's what we talk about. I don't know the laws of Delaware, but I do know about credentialing Delaware. So in this state, a quiet overachiever is what I would call it. Or is it just quiet? I don't know. Maybe that's what we're going to talk about today on Credentialing Chronicles.
Yeah, because, Delaware is a small state with really a centralized healthcare market, fewer major hospital systems, and really tight professional circles. So really the question isn't whether Delaware has problems, because we all know, like every state does, we all have to deal with different things, different pitfalls. But the question is, does small make it easier to really manage risk, or is it just easier to hide it?
Oh, that's a good question right there. Okay. Because when we're looking at, we're looking at tight networks, it could mean better oversight. We might come out of Delaware, y'all.
Right. True.
And we might say, everybody knows and nobody talks. How many times do we see that?
True. But before we spill anything today, we do need to say this clearly. We have never credentialed any of the providers, practitioners, physicians, professionals, any word we're trying to use, or entities discussed in this episode. We're using publicly available reporting, court decisions, and government press releases to really analyze the events through a credentialing lens and compliance vision. So we just need to make sure that we say that.
Did y'all hear how Nyleen's voice changed? Should have got all professional on us. Y'all better tell Nyleen.
I just want to make sure we don't get sued by nobody.
For a minute, I said, is that Emily again? Who is this? Oh, my goodness. Okay, Nyleen. Well, she said I got to say some stuff too, all right? But here we go. This is educational. We're not determining liability. We're examining, you all, how oversight systems function, right? That's what we really want to talk about. And sometimes they fail, right? And really, that's what we want to talk about. That's where we're spilling our tea. But what that means, right, when we're looking at for patients, which is, I have to tell y'all, our audience is growing. Like, follow, share. Patients are coming on board. We're getting patient questions and patient comments, and we are so excited. And what that means for MSPs, and then what does that mean for our trusted providers, the good providers, the real providers that are out there doing the hard work and not actually scamming the system, right?
Right, because really credentialing isn't about gossip, right? We're not here to ruin anybody's reputation. We're here to bring awareness, and really it's true governance, right?
It is.
So let's spill some tea. Okay, so before we go ahead and roast Delaware, we're giving credit where credit is due, because Delaware has something that many states still struggle to build. It's this thing called the Delaware Health Information Network. And the DHIN says it launched in 2007, and it really serves all of Delaware's acute care hospitals and reaches close to everybody of the state's medical providers, delivering millions of clinical results each year.
I mean, when we looked into it, Nyleen, they say, nearly 100% of the state's medical providers are plugged into this network. So I guess what we're asking, if Delaware has this kind of statewide, data sharing, doesn't that make credentialing easier, cleaner, more tidy?
Right. Well, I mean, it can, but just not automatically, right? But it does reduce excuses, I guess you can say, because really the infrastructure supports credentialing indirectly by tightening things like directory accuracy, like who's active, where they practice, mismatch detection, quality reporting alignment, outcomes, utilization signals, and then monitoring triggers, which is not necessarily primary source verification, but like something changed alerts.
And I think when, we're looking at that, what are you thinking, Miss Nyleen? Are we thinking like, is it an infrastructure participation, like the total infrastructure is participating? Or is it sloppy credentialing? Is it oops? In a state that has this infrastructure, is there still sloppy credentialing? You know what I'm saying?
Well, I mean, just because you have a strong infrastructure, it really doesn't eliminate fraud, right? But it makes it harder, I guess, to pretend you didn't have tools to do that,
Yeah, definitely. And I'm right there 100% with you.
Right. So let's talk about like workforce reality. Stabilizing doesn't necessarily mean healthy, right? It means not collapsing. And even in stable states, shortages hit really unevenly.
Yeah, and when workforce is stabilized, do we get better compliance? I mean, that's really what I guess we're kind of talking about today. Or do plans still rush because shortages don't disappear as they wish they would? So I guess it's a fragile, ladder all the time. What is that? What is that scale? Oh, scale. The justice scale. You know what I'm talking about?
Oh, the justice scale. Yeah. The up and down. Well, that's just it. So when you have a thin pipeline of specialties, there's credentialing pressure, right? So especially in areas like we've talked about behavioral health and primary care, because that pressure shows up like, oh, we got to expedite. We got to do this thing called temporary privileges. We got to do this thing like accept pending, right? Or we'll clean it up later.
And, we see that all the time. And really, what does that equal? Later equals risk becomes permanent, right? I mean, if you're saying later, know that you have risk.
Right. So
you look perplexed, Nyleen.
I am, because I just love how, things can just get so mixed up when we talk about different states and how different states do things. It's actually really, really cool. Can we talk a little bit about like money? Did you find out anything about money, or like what's going on with money and reimbursements in Delaware? Like what's going on with that?
Well, yeah, I mean, money writes the plot, for a lot of states. Delaware reported a 9.1% per capita healthcare spending growth. But this is coming out of year 2023. And that, is above its benchmark. So I guess, whenever money gets tight, compliance, of course, gets squeezed. That's one of the first areas that they kind of take from, as we know.
Right. So then like cost pressure changes behavior, I guess. So credentialing as like a throughput machine, we got to do it quicker. And then audits turn into like reactive instead of proactive, because if the healthcare market is growing so quickly, right, then we're talking about how fast we can enroll somebody. And we're not really worried about file integrity. Delegated credentialing is pressure. We got to do it faster. There's more data corrections, because then obviously the rush is going to create errors.
And it is, and it does. And what happens all the time? We've talked about it in other episodes, Nyleen. The first people, let's downsize the credentialing team.
Right. They're just the paper pushers.
Susie can handle 900 providers. and you're like, oh, Susie.
I heard the craziest thing today. I heard one person was handling 1,200. Even with the CVO, that's too much for one person. That's crazy.
That poor lady or man, they are working around the clock.
Right?
Yeah, I mean, that's a lot of emails. That's a lot. But again, that's what we're talking about. I mean, you can't downsize the team that is really your compliance gatekeeper, right?
Right, exactly. And so I just, it's done quietly. Sometimes they're just like, oh, they're just admin, they're just risk control, we don't really care. But the reality is we're seeing if you have such a uptake, you got to do something about it.
Say it for the people in the back, Nyleen. And then leadership, what do they do every time, right? Everybody's so shocked when the scandal invoice arrives, when, a provider slips through the crack because, one staff is dealing with, 1,200 providers. Just took your breath away, girl.
I just can't, that's just, it's just crazy. So let's talk a little bit about behavioral health, because behavioral health is, I know it's dear to your heart. We've talked about behavioral health in other states a little bit, but really, what kind of behavioral health gaps did we find in Delaware?
Yeah, I mean, really looking at all of the numbers, where are the numbers? What's the average credentialing turnaround time in Delaware? Something that we really were trying to come up with. What's the recredentialing compliance rate? And how many files fail internal audit? And, a lot of that information can be found on like a public credentialing, KPI dashboard. And Delaware has no statewide credentialing, mechanism to kind of report those items.
A lot of states don't, and really, that's just, it's just interesting how it all changes state to state, and whether or not we should be reporting those types of metrics.
I think for a transparent system, though, we should. There should be some type of. It keeps everybody honest, especially now with CAQH going, under the plans.
Public.
Public under the plans. I mean, it's just now even more shroud in secrecy.
Right. Well, silence doesn't necessarily mean excellence, right? And if nobody's measuring, then it doesn't matter. So if we're rushing credentialing and we are not measuring metrics, let's talk a little bit about that behavioral health gap. So what's going on with behavioral health?
Yeah, definitely. I think behavioral health is always the canary in the coal mine, for a lack of a better analogy. When there aren't enough providers, what happens? Credentialing gets rushed, like Nyleen said. And that's, what we see, number one.
Well, and unfortunately, that's what's going to turn into like incomplete files and directory mismatches and expired items slipping through. So if we don't have a mechanism to track or hold, systems accountable, monitoring failures will happen, and then you're going to have an overloaded system. So then what does that have? What does that lead to?
And it will. Hello, we know what that leads to: patient access problems all day, patient safety problems. And really though, what you're talking about is the things slipping through the cracks. Even one of the biggest things is the disclosure questions. If you don't have somebody that just is there about the file, and you get an NPDB, you get a sanction, something has come back and they have checked all no. That is something that has to be cleared out. That is a red flag all day. Nyleen, you know that. You have 1,000 certifications.
Yeah, and for the patients out there, it doesn't matter what state you're in. Every physician, nurse practitioner, PA, anybody that's applying for anything has to answer these quote unquote disclosure questions. And the disclosure questions include everything from, have you ever committed a crime, to, are you currently using drugs? Have you ever used drugs? Have you had a malpractice lawsuit? So there's all these required disclosure questions, and we're supposed to be looking through them, reviewing them, and then verifying them, right? getting those background checks, getting those NPDBs, getting those claims histories to make sure that what you say can be verified. So
100%.
is it just administrative paperwork, Shannen? I don't know. I don't think so, right?
No, it's not. And but really what happens is that's how it's treated. So when you treat something like an administrative paperwork, an inconvenience, then that is what the culture, right? That's what the culture treats it as. I mean, even the doctors, I mean, when I go out and I consult with clients and they say, the doctors, they're not moving, they're not doing nothing. I always say, number one, if you treat the process of credentialing nonchalant, then you have a whole staff of doctors that are going to treat it nonchalant, and that's something that's really kind of, something that needs to be, you cannot even get onto our EMR system until you're credentialed, babe.
Okay, so Shannen, let's do like a rapid fire Delaware hot takes. Like, what do you think?
Okay, so like a credentialing type of, is it a gym or is it just a hot mess out there in this world?
Yeah. So I would say gem infrastructure, but like mess potential.
Oh, totally. I think you're right. Would you want to run delegated oversight over there? What do you think about that?
Actually, well, yes, but only with strict audit cadence and like zero friendly shortcuts.
Yeah, it would seem like you cannot be friendly over there. I mean, in a small state, is it easier or harder? What do you think?
I'd say harder because relationships can interfere with reporting. So small, tight-knit, cause some problems.
Well, I gotta say, if you are in Delaware and you are listening to this episode, can you tap in? Can we get a DM? Can we get some likes, some shares, some follows, subscribes, right? Is that everything that we're supposed to ask for? Tell me. Okay. We got to do it. Okay. So tell me, what do you think is the biggest silent risk?
Yeah. So I think low noise being mistaken for low risk.
Nyleen. Okay. Biggest opportunity, babe. Tell me.
Well, then I guess the use of that DHIN level infrastructure to go ahead and tighten verification, monitoring, and directory integrity.
I know. And what if they taught other states how to do that? Like, how incredible would that be, right?
That would. And maybe it can be adopted for bigger states.
Yes. Delaware. Opportunity.
But if you've stayed along this long, we got to do my favorite segment.
Oh, no. It's the murderers, y'all. The murderers. She got some.
I love some scandal.
She got some Delaware murderers.
Well, we got some scandal because every state's got some scandals. So we talked about some good stuff going on in Delaware. Let's talk about some scandals with our doctors in Delaware.
Okay, I'm ready. You got my attention.
All right, so the next part is where Delaware stops being quiet and we're going to do on some crazy stuff.
Yeah, not crazy stuff. Look, Delaware, are you operating on excellence or just low noise? Because Nyleen out here talk about the noise.
Ooh. All right, well, let's start big. A major Delaware health system paid $42.5 million to resolve allegations of healthcare fraud under the Federal False Claims Act and Delaware's False Claims Law. And this case began actually as a whistleblower complaint filed years earlier. Allegations were that the system provided free or below market support services, including nurse practitioners, hospitalists, physician assistants, to non-employed specialists whose patients were hospitalized within its facilities. And the theory is crucial because those support services could be considered like a remuneration, which is something of value intended to induce referrals. So it's a whole scheme of referrals within each other. And girl, it's millions upon millions of dollars.
Like a passive scheme. You wouldn't even really know it was happening if you didn't really know. So I guess, can you explain that to because Nyleen, our patient population is growing. They want to know. People are like, what the heck is credentialing? That's really what the people tell us. And so can you explain it to me? I am 5 years old, right? Why is giving a support staff, why could that be considered a kickback problem? I'm 5 now. Tell me I'm 5.
Right. So because if a hospital covers costs of a private physician right? Or that a private physician would normally pay, then that's considered a financial benefit. And if that benefit influences a referral pattern for Medicare and Medicaid patients, because we know those are the federal government programs, then we're in the anti-kickback statutes territory. We're in the Stark Law, which is a self-referral territory. We're in the False Claims Act exposure. So if claims flow from prohibited relationships.
Man, okay, so what you're saying, and this is for our patient population, and maybe even new MSPs that aren't certified yet, right, Nyleen? Yeah, okay. So what you're saying is that there are laws, okay, that have already been established so that providers don't do fraud? Is that what you're saying?
Right. So you can't control where the referrals come from. It's supposed to be a free system market. Everybody is supposed to be able to choose where they receive services, whether that's an X-ray, a primary care doctor, or whatever. It can't be a closed circuit. You have to give the patients the option to have their care wherever they want.
So wait a minute. So Susie is my grandmother, and she goes to see the doctor. And the doctor says, hey, Susie, I need you to go get an X-ray. Go over here to ABC Radiology. Is that what you're saying?
Well, it depends. Does he have ownership at that facility? Is that facility owned by that hospital? So technically what happened is once certain laws came out, we would have to particularly say, and people do it in like really fine print to make it compliant, but they would say, well, we recommend that you go here, which is where the doctor had a facility relationship with, or it was owned by the hospital that employed him. But they also have the option of, oh, by the way, there's these other places you can kind of go to, but that's like in really tiny, tiny, small letters. So the problem is that if a hospital is going to cover certain fees, it's just the way the kickback works is you can get into really shady territory.
So what does a patient say? Okay, now we have Susie. My grandma's there. She's so cute. Her outfit is cute. Her nails are done. And she's got to get her X-ray. So what should she ask, Nyleen?
Where she goes, what are my options for having an X-ray? What are my options? Who can I see? And obviously, they're going to send you to somebody in their network, but you as a patient have the right to choose where you want those healthcare services rendered. It does not have to be somewhere within that healthcare group or somewhere that's owned internally by either the same physician or that hospital.
Okay, period. So you heard it here. I will say just on a contracting level, you do have to make sure that your insurance is still taken there, just FYI, because that's still important.
Absolutely.
Yeah. I don't want people to say, wait a minute, you didn't say nothing about insurance. We're going to tell you. We're going to tell you, baby. We don't miss no details.
Yes, that's the most important.
Yes. Okay. So, let me get off. We was going down a rabbit hole, girl. I'm backing us up. Okay, so what would credentialing professionals, because we don't talk to the patients, and medical staff leadership be asking in these type of situations?
Good question. So there's 4 buckets. You should have the employment status clarity. So is the provider employed, contracted, or independent? Is the relationship documented? Is there a, conflict of interest statement, fair market value and written agreement. So are services valued, are arrangements memorialized? Is there, like I said, a conflict of interest and referral risk? Does the relationship create a referral incentive? So, hey, I'm Dr. Jones and I want Dr. Jones, if he sent this facility, 20 because he sent 20 referrals, he's getting a kickback. That's a kickback. You can't do that. Governance integration. Is compliance integrated into privileging, onboarding, and reappointment? So those are your sections.
And I'm just going to let y'all know again, because that's my friend. She's got about 92 certifications. They all be behind her last name. So that's how we can talk about all this to just provide some governance, okay? Just a little governance. Okay, so really an important note, let's be honest. These were allegations resolved by settlement. So they were not, a determination of liability. So that money that she was...
Our favorite word, allegedly.
This is all allegedly because, the things were settled. So, yeah, we're trying to give you the good information.
Exactly. So the government states the claims resolved our allegations, but the credentialing lesson stands. When financial relationships aren't controlled, credentialing becomes a paper shield and really not a safety system. And those conflict of interest statements, guys, make sure you're collecting that conflict of interest at credentialing, initial reappointment, all of that.
Yes, and yes, because ultimately your job is to protect the organization, the provider, as a medical staff services professional, and you need to make sure that all your dots are pointed and all of your T's are crossed in that credentialing file.
Yeah, so let's shift to the darkest kind of oversight failure, which is the kind that doesn't just cost money, it costs childhood. And this is a crazy story where I found a former pediatrician in Delaware was convicted on multiple counts involving sexual abuse of child patients, and received multiple life sentences. Court summaries reflect convictions and sentencing, of mandatory life terms plus additional years. And here's the line we need to say out loud because it matters for the reporting conversation. Okay, according to USA Today, this case also raised serious questions about how concerns were handled across systems and whether reporting and escalation failed far too long.
And this is what we see every day. And we're going to say, what does this have to do with credentialing? But we always come to this point, right?
Right, everything, because credentialing is not a one-time license check, guys. It's truly ongoing practice evaluations. It's peer review. It's mandatory reporting. It's board communication. It's reappointment as surveillance, not just a rubber stamp. And then in later appellate reporting, the case discussion included claims about ineffective counsel and asset restraints affecting, counsel of choice, showing how complex the post-conviction process became. This guy kept using all these excuses, and the reality is it doesn't matter. He used his healthcare license, whatever it was, to commit a crime and hurt our patients. And I know, it's not every doctor that does this, but for the doctors that do, it's a violation of treatment as us as patients.
Yeah. And I mean, if something goes down, where is the first place they're going to go? All the time, credentialing file.
Absolutely. It's the first thing
it's the first thing they pull, you guys. And so for the new MSPs that are out there, for the patients that are out there, as soon as anything goes down and there's a lawyer involved, they say, we want the credentialing file. And they're checking your work, like an auditor, like with the toothpick. And they're saying, did this person verify? Did this person piece together everything that they could have found out? And that's an important, that's an important job. And when we talk about that, like, what should MSPs learn? I mean, there's so much, but specifically operationally.
Exactly. Well, obviously, red flags are not soft. If you get that gut feeling, it's a red flag just as much as a lying piece of information on their file. Right? Unprofessional conduct, boundary issues, complaints. Obviously, they all require documentation and escalation. Reporting isn't optional, guys. Silence is a decision, and delays create victims. And then reappointment is where you really catch what hiring missed. If reappointment is treated like just a clerical renewal, then the system stops protecting patients. Reviewing that overall quality data within a facility, how many times a doctor blew up, how many patient complaints, that ongoing professional practice evaluation is all encompassing as part of your reappointment, which is why quality is supposed to be part of your reappointment.
Yeah. And I mean, really, let's say you have, Dr. Sarah, and Dr. Sarah is beating her husband, and Dr. Sarah comes on to the hospital, and you do the background check and everything is cleared. And then guess what? Dr. Sarah continues to beat her husband, and now she has a domestic violence on her record. And so that's one of the reasons why Credentialing Chronicles is always going to advocate for background checks on re-credentialing as well, because you might not have caught it on the initial when we do that background check, but on the re-cred, you can catch patterns of behavior, because patterns of behavior are usually, have exposure. So again, we're always going to say, good recreds are mandatory, you all.
Girl, we're winding down, but I got another story. I got a story about a pill mill, girl.
Honey, we done seen a pill mill in every state.
Every state? What is going on? Yes, this opioid epidemic, it's a thing. So
wait, really quick. There's so much oversight. How?
Right? Like, how do you even get away with this? Like, I wouldn't even know where to start.
And John hurt his back, and they talk about here's a little Tylenol in the hospital. Where's all the pills going?
Right?
I'm sorry. I had to ask.
Going to the pill mill.
They're going to the pill mill. The pill mill people been coming out around midnight picking them up.
So anyway, this former Delaware physician was sentenced girl to 20 years in federal prison for unlawfully distributing controlled substances and maintaining a drug involved premises. So the DOJ, I got this information from the DOJ, described prescribing powerful opioids outside professional practice and not for legitimate medical purposes, including high dosages and then dangerous combinations often linked to cash payments. So cash for some pills.
I mean, this is literally the same story you told me about Florida. I mean, cash for some pills.
Cash for some pills.
Okay. So for listeners, you all, if you ever came by a pill mill, comment below. We want to hear about your story, okay? But what separates a legitimate pain care from criminal prescribing? I mean, how does the average patient know that, Nyleen?
Well, that's a really good question, right? So there's medical necessity, documentation, standard of care, patient evaluation, plus responding appropriately to red flags. Because credentialing and privileging intersect here through like DEA related monitoring signals. I mean, here in Georgia, we have this thing called the PDMP. So we have peer review quality, reappointment review of adverse actions, and then we have controlled substance policies, right? So our primary care doctors over prescribing Percocet, we should be referring those patients that are on chronic pain medicine to those special pain medicine providers, physicians that are, monitoring them, doing drug tests. So I used to work for a pain medicine physician, and he would do drug tests. Every time a patient came in for a follow-up, they had to have drug tests to make sure there were no other narcotics being used, because they had to take certain levels. Certain levels are monitored. In the state of Georgia, you have to run a PDMP before you see a patient to make sure. As a surgeon, we're prescribing opioids because they're having surgery. How much are we prescribing? Ensuring that there's safe limits. Are we prescribing 8 pills? Are we prescribing 15? And then the patients are coming in before that refill is due to make sure, hey, do you really need another pill? So are those practices being monitored within the patient care setting is what we really need to follow up. And guys, if you work in a medical office, I understand a lot of this stuff doesn't even get to the credentialing office, but if you work with doctors, watch prescribing practices, because y'all know exactly what the doctors are doing every day in their offices.
Nylee's talking about the over-prescribing and all of that, but the under-prescribing too. If you see a doctor that's scared to prescribe something and Tommy done fell off a ladder and back broken in 3 places, he's talking about here's the ibuprofen. So again, advocacy is, a nurse's number one superhero tool, let's be honest. And, your job is to advocate for your patient. And so, just make sure that there's advocacy happening, because I get it. Some doctors are scared. Because prescribing authority is a privilege. It's not a right. And honey, everybody's trying to get a hold on what, Nyleen's talking about, this opioid pandemic. And so some doctors are scared, and so they don't want to prescribe nothing. But again, there is some pain medicine that, that is needed for true pain, right?
So now we talked about some pill mills. Girl, can you remember when we talked about Operation Nightingale in Florida? Girl, this Operation Nightingale is hitting all the states.
I was going to say, as we go through spilling the tea, we have uncovered it in many states.
Yes, so apparently Delaware reported 26 nurses were informed that their nursing licenses were annulled in connection with this fraudulent diploma scheme.
How does that even happen? I mean, people here, they passed a board, and what do they assume? That there is competency in that.
Right, and that's the scary part. The scheme exploited the fact that someone can use fraudulent education documentation to qualify for licensing exams. So the HHS OIG notes the scheme involved fraudulent diplomas and transcripts tied to these Florida schools. And it's like, okay, we already spilled that tea on Florida, which we haven't even done Florida yet. We did this in a previous episode, but I can't believe we're finding states on and on and on. So what are we going to do?
Well, I mean, that's the thing, right? I'm going to say it. You might sit and process 100 files, and 101 file might be a Nightingale person. So you can't get lazy with it. I mean, it's very important. You have to stay vigilant, because there are so many licenses that have licenses that have went out under this Nightingale operation. But truly, Nyleen, please take a note out of your book, out of your Nyleen book of all things compliance, and tell the MSPs what should them and HR do before something like this hits their facility, my love.
Of course, verify education, primary source verification, recheck any credentials from implicated schools, like tighten clearinghouse only reliance, ensure continuous monitoring catches retroactive actions. Like, you've got to have this ongoing thing. And this is why we love Baton, because Baton helps organizations verify these provider licenses efficiently across states and supports continuous monitoring, which matters when you're dealing with things like multi-state enforcement actions, telemedicine expansion, board actions and sanction signals, exclusion risk environments. This is why Baton Health is such an amazing platform and really should be used by everyone, because it's going to cover everyone, not just physicians.
I know. And really, let's be honest, manual tracking, baby, isn't where it's at anymore. Baton.
Credentialing teams deserve technology that works as hard as they
Yes,
do.
they do.
So that's why I got my last story of the day. My last story of the day, I know we've been on here forever. Girl, there was telemedicine and genetic testing fraud.
Oh my goodness. How did that happen?
Telemedicine-driven orders for unnecessary genetic tests, girl, and DME. Hallmark red flags, minimal patient contacts, scripted calls, high volume ordering, and then, of course, Medicare billing spikes. What do you think AI is going to do? 1, 2, 3. Let's see where the scheme is.
Every time, especially now with the AI, it's not getting very far. In credentialing terms, what should be different for telemedicine privileging? Tell the people at home.
Well, your telemedicine privilege files should scream controls, right? State licensure compliance, scope of practice supervision rules, documentation standards, audit triggers, quality data review tied to telehealth encounters. And telemedicine can be ethical, but really volume that exceeds clinical plausibility is just a compliance siren. We really need to monitor. And one of the things that was really interesting at the hospital that I'm working at now is they want time. So how long was a telemedicine provider actually providing the service to the patient? They want actual times to be able to bill accordingly and make sure that all those services were actually rendered. So really good.
And again, I'm just going to put it out there. This is exactly why we're proud to highlight our sponsor, Baton. They are just always on point. And we don't credential the providers, but honey, we do verify them.
So let's do our final PSA segment. Let's close this out with our PSA.
Well, Nyleen,
and
you
so
kick it off, baby.
PSA.
Kick it off with the doctors.
Okay, well, your license is your livelihood, doctors, and your documentation is your defense. So avoid financial entanglements that blur your judgment. Stay inside the scope of your practice. Treat prescribing as a privilege, not an entitlement. Give the medicine to who actually needs it. Refer it to somebody else if they need ongoing management. And if you see something unsafe, please, please, please report it.
Yes. Okay. And I'm here with the PSA for the MSPs, which stands for Medical Staff Superhero Professionals. Well, I added the superhero, but I love you.
Okay. I like medical superhero.
Medical staff superheroes.
We're going to change the term.
Exactly. So credentialing is governance, right? Verify education thoroughly, monitor continuously, escalate any red flags. And I'm going to tell you number one, trust your gut. Trust your gut. Because everything could check out and you could still have a gut feeling and your gut is telling you. And if you have a story about that, drop it below, send us a DM. We'd love to share it on, one of our episodes or in some of our bonus material that'll be coming out soon.
Yeah, and for healthcare leaders out there, transparency prevents your scandal. And whistleblowers are warning systems. Compliance officers should be empowered and not silenced. Our risk managers, love them, love them, love them. Risk managers are going to help us throughout our organizations. And really, cost pressure is never an excuse to cut the safety net.
Ooh, I like how you put that. Okay, and I'm going to talk to our growing patient population. Hey, y'all. How y'all doing? I'm so happy that you've come. And I don't know. I figure, what are we in right now? Let me look at our timer. If you spent 41 minutes with us, I'm going to love on you.
Listening to us.
If you spent 41 minutes listening to some credentialing craziness, okay? Let me give y'all some little jewels and nugget. Here you go. So you're going to ask people, who reviewed my provider? Who reviewed my provider? Is my provider good? What's the credentialing file look like on my person? It's okay to ask that, you guys. Ask. Advocate for yourself. When were they last reappointed? Did you find anything in the reappointment? Ask. The more you all ask that, the more this will become just normal, okay? Is their license active and clean? Yes. Honey, you remember, go to our show notes. You can do it right there and check it out right there, and you can find that answer out for yourself. Who monitors quality and complaints? Now, this is a requirement that is from CMS, from NCQA, honey, all the accreditations say they have to monitor quality and complaints. And so you get to ask that question. And if you do ask that question, if you're in a healthcare situation and you did something like that, or you felt a little shy and you didn't want to, drop a comment below. We love to hear about you. We love to make sure that in your next appointment you have some chaperone or some help, right?
Yes, because patients deserve care that's safe and not just available, right? We want you guys to get the best, safest care possible. Okay, so Delaware may be small, but the oversight stakes are huge.
Credentialing is not paperwork. It is not. There is a lot of paperwork involved, but it's not just paperwork.
No. It's protection. And when protection fails, scandal becomes history.
Stay credentialed, not canceled, baby.
That was a whole nation's worth of tea, girl.
Ooh, and we are just getting started. More states, more scandals, and definitely more receipts.
And if you love the tea we're spilling, you gotta like, you gotta comment, follow us, share, do everything. Where can they do all that at, Nyleen?
They can follow us on LinkedIn, Instagram, TikTok, Facebook, on all the things. And share it because the tea is going coast to coast.
Ooh, I love it. See you next time on Credentialing Chronicles. Remember, you got to stay credentialed, but not what?
Not canceled.